As I mentioned before, when in doubt, get a new scan body and try it again. If you get the white show through, if you force it in there and it feels too tight, then chances are really good it's incorrectly oriented. Now, one other reason you might have to put a lot of pressure is if your implant is too close to an adjacent tooth. If it's too close to the adjacent tooth, then you may not actually have enough space without intense pressure to get that scan body to place, in which case you're probably doing one of two things. You're either deforming the plastic of the scan body, or you're actually temporarily, hopefully, moving the tooth by putting pressure on that PDL. So practice outside the mouth, but you have to pay close attention to this. This is, as I mentioned before, the scan body is the most error-prone step of the CEREC design process because it's so easy to misalign it. It's a little bit challenging, if you will, to align it correctly. All right? Okay, so let's talk about imaging. We want to image several things, obviously. There's one that I'm going to add that you may or may not be using, and that's the gingival mask. When we're imaging, we want to make sure we get the restoration arch, obviously, and that'll have the TiBase or the scan post and the scan body on it. The opposing arch, obviously. One thing here, you want to make sure you take the scan of the opposing arch and the buccal scan before you put the TiBase or scan body in. If you attempt to have the patient bite down and there's not enough space over here, the patient will be biting on the scan body or the scan post or the TiBase, and they could potentially deform it or chip a tooth or potentially cause some significant issues for the integration of that implant. So when we're doing this buccal scan in particular, I would do that first before you even put the TiBase or the scan post and the scan body in place. Get the buccal scan with the patient biting all the way together, and then put the TiBase or the scan post and the scan body in place. Then get your restoration arch, your opposing arch, and then your gingival mask. And the trick with the gingival mask is, what I like to do, since we're working on the lower left here, is I'll scan the lower, I'll go up here, and I'll show you this in a minute, add the gingival mask, which will pop up down here, and then I just copy the lower, or the whatever arch we're restoring, to the gingival mask. Okay, so you can see how I'm copying that, moving it over there, and I'm copying it. You saw how I hit copy, right? Copying it over there so that we have the same data. Now that's the gingival mask that I copied over the restoration arch. This is obviously an upper. This is not the same case we were just talking about. But then you can cut it out. I'm going to cut out that, just take the cut tool, cut that out, and then I'm going to go ahead and scan into that. So let's watch that for just a moment. So what I just did is I cut that out. I've looked for this red check to make sure there's enough common data. And this is cycling back through. So you see I have the gingival mask, and this goes both ways. You can either copy or move. So I'm going to copy it over, and then I'm going to cut that area out. And then I'm going to look for that green check before we move forward. And I use this all the time when I'm doing a biocopy. A lot of times the assistants will go ahead and do the imaging before I get to the room after I've anesthetized the patient to make sure that we're ready and moving forward. But that's one of the techniques I use to kind of speed things along. All right, so lots of arrows here. Basically what the gist of it is, over here you can add a catalog, and I'm going to select the gingival mask upper or the gingival mask lower depending on which arch I'm restoring, and then that one will go down here. Now there's even more arrows. Isn't that fun? And then, like I said, what I like to do is I like to copy the restoration arch, just copy it over into that. And as I mentioned in the previous video, this is something that will come in handy when we do our cutout, when we trim around the TiBase or the scan body, because it tends to put a trough through the modeling. So it's helpful to have that gingival mask. Can you do without it? Most of the time, but I would always encourage you to make sure you have this mask, whether it's the upper or the lower. Can you do it with the Biocopy? Sure. The mask is a little simpler. The computer tends to move faster. Okay, let's move on. Setting the model axis, cutout restoration axis. Okay, so setting the model axis, this really is critical in enabling the software to know what area of the mouth we're working on. So I like to start on the left side here. I will go ahead and orient the model. Make sure that the occlusal plane is roughly parallel to the floor and that it's lined up roughly vertically. And then I'll move it over to where it needs to be. Obviously lower left is over here. In my experience, this area is more critical than this area depending on which design mode you're using, but it needs to be correct here and on this side of the screen as well. So you got to do these steps. You can see this is designed for molars, premolars, and anterior teeth. So we've got our anterior teeth, and this is a little too far forward, molars, and then premolars. So that's a molar, so ideally we should have moved that one back a little bit, but it'll do the job. Okay, first step, trim area. What I like to do is a real narrow trim right around the TiBase. Some people will do what's called a pancake. They'll trim through here. The point of the trim when you're trimming is you want to conserve the adjacent tooth contacts, because if you end up trimming through there, you have nothing. Let me write that out. Nothing with which to actually design your proximal contacts. So you have to make sure you preserve the interproximal contacts. And that also is where that gingival mask comes into play. Okay, we're going to verify the cutout, make sure we have enough data. Make sure that the TiBase itself, or the scan body itself is visible enough and has enough data for the computer to work with, especially this pyramid on the top. That's really critical. The pyramid is absolutely critical. Then the next step after we've done the trim area is clicking the scan body head. And you want to center right in the very tip top. The very, very top of that pyramid is where we want to touch. And please remember to zoom in, use that center button on the mouse pad and zoom in so you can get a real clear picture. All right, and then we're going to double click, click. And sometimes it'll say, you need to do it again, it'll give you an error. Zoom in, try just slightly off where you were before, but again, try to be right smack in the center of that pyramid. All right, next step, edit the baseline. I know we talked about this before. Editing the baseline basically is telling the computer where the CEJ is, where that root surface meets the enamel. And in an ideal world, that should be where the tooth comes out of the gingiva. That's the emergence area, emergence location of the gingiva. So we don't have to spend a whole lot of time doing this, but you can see how the computer proposed it here. So I'm going to double click, and then I'm going to bring it up and out, bring it around, and then I'm going to double click again, and then it'll give me a new proposal. You can double click to start, double click to stop, edit it as you need to. This can be edited later on in the process. It does not have to be perfect right now, but for all intents and purposes, I would make sure that when you're doing this, that you get a fairly normal shape with your emergence profile. If I were to have left it here, where the computer initially proposed it, my emergence profile from the TiBase would have been really, really wonky, really strange. It'd be hard to work with. It'd be a lot easier to go ahead and give you a much more natural emergence profile from the outset. But again, the goal is to match the CEJ. All right, so that's my final baseline initial proposal. And again, this can be edited later on. So it's not something that we have to set in stone. This line can be edited later on in the design process. All right, restoration axis. This is a little different, as we mentioned in the previous video. A little bit different than your standard crown, bridge, veneer, inlay, onlay path of insertion. It's controlled with this toggle wheel over here, a little joystick. So when the modeling initially appears, if I were to move, let me draw in here a little bit, move the joystick left, then this arrow is going to go to the left. All right, if I move it to the right, same thing, it's going to lean over to the right. And then, of course, buccal and lingual, you know, it's going to move buccal, and lingual is going to move the other way. So now, if I reorient this modeling, it's not necessarily going to change the orientation. Still, if I go left, it's going to move to the distal, et cetera, et cetera. So you'll figure this out. It's a little bit unique, but we want to use this as our focus point rather than positioning the model like we normally do with our path of insertion for a crown or a bridge. A lot of people get hung up on this and they can't figure out why their restorations look so weird in the proposal. It's because we aren't using this joystick well. So make sure when you're setting things up that you focus on the joystick. Let's see if I can get all those marks to disappear. There we go. So focus on the joystick. Use the joystick to design your restoration. To design your restoration axis. Sorry. All right, so see how I moved it just a little bit this way and it's leaning up just a smidge. And this is something that you can't change later on. It's locked in place. You'd have to go back through all these steps and do it again to get your proposal. All right? Okay, so there's another view of that. And here's that trough I was telling you about. Depending on how wide that tooth is, if I were working over here, that trough would probably cut through the adjacent teeth. So I would want to make sure that we get a nice clear image of the adjacent interproximal surfaces, and that requires that we spend a good amount of time getting the appropriate data, so we need that, gingival mask image set. All right? Okay, let's talk briefly about parameters, and then we'll conclude this video. Parameters, I would recommend that you don't change them at all. Let me go back. When you hit next here, after you've defined the insertion axis, when you hit design, it'll take you to the parameters, this page. I would just leave them alone. Don't change them at all, because most of the design process will happen later on. All this stuff you can change if you want to, but it just makes it more difficult. And until you've done a few hundred of these, leave this stuff alone. Don't change it at all. Leave it alone, okay? So don't touch it, leave it alone. Just move on to the next step, okay? Good question for you. What is your cement's film thickness? What is your cement's film thickness? Now, if we're using a multi-layer, what kind of film thickness do you have? That's a question for you to look up. I would recommend getting your packaging out, whether it's Veralink Aesthetic or NX3 or whatever cement it is, and look up what you're using. I like to use Veralink Aesthetic. That's my favorite one. I used Relax Ultimate a lot, Multi-Link a lot. It varies, so if we're doing a cemented crown, we need to know this. This is kind of academic right now. But here are the cement thicknesses from the manufacturer's packaging. All right, Relax Ultimate's 12 microns. Multi-Link is 20 microns, and Veralink is 50 microns. So these are different, right? Now, when you take into consideration what kind of hydraulic pressure is going to be delivered upon the abutment and the crown interface, you may want more than just 12 microns of cement thickness. Excuse me. So this is important that we know this. And again, this kind of goes into why I would recommend not changing those parameters, because most of them are done intentionally. Probably all of them are, not that I know everything about CEREC, but they're probably all done intentionally so as to facilitate the best long-term restoration. So you don't necessarily need to bring your cement thickness up to 200 microns. Leave it alone and just move forward with the next step. Alrighty? Okay, so we are going to stop here. We'll jump into the initial proposal and editing in the next video and really dig into the process of how we do that. Okay? Thanks for watching. See you shortly.